Welcome back to EmergiQuiz, everyone. Thank you for jumping back in for my case titled The Purplish Puzzle Part 2. I'm Sandhia Arrora, the second year Pete's Emergency Medicine Fellow from Dayton's Children. So just a quick recap of our case. 10-year-old female who presented to the ER with AKI, thrombocytopenia, rash, who was also found to have elevated inflammatory markers. Patient was admitted to the PICU under nephrology consult. On arrival to the PICU, patient was in anuric renal failure and hypertensive. Her blood pressure reported in ICU was 155 over 89 millimeters of mercury. She was started on maintenance IV fluids with Lasix challenge and it did not show any improvement or response. Patient was then started on hemodialysis 18 hours post-admission. The picture on the right corner, as you can see, is the first void post-HD, which suggests gross hematuria. Patient had broad workup done in the ICU to find the etiology of her illness, which consisted of infectious, hematology, renal biopsy, genetic, and even immune workup. There were a lot of differentials considered in this patient case. However, for the time's sake, I will be just discussing a few today. So the first differential that I'm going to discuss is IgA vasculitis, formerly known as HSP. As the name suggests, HSP is a vasculitis characterized by tetrad of palpable purpura with neither thrombocytopenia nor coagulopathy, arthritis or arthralgia, abdominal pain, kidney disease which consisted of hematuria, proteinuria. Having two or more above findings increase the sensitivity and specificity of HSV to 90%. Our patient, however, did have some rash, but it was not palpable. She did have thrombocytopenia as well as coagulopathy. She did not have any arthritis or arthralgia. She did report some abdominal pain, and however, she did have some kidney disease. The next differential is microscopic polyangiitis. It is a rare form of vasculitis. Patients are usually C-ANCA and P-ANCA positive. Affects various organs including kidneys, lungs, skin. The kidney biopsy findings shows characteristic crescent-shaped proliferation of cells forms in the glomeruli. As you can see on the right corner, there is a crescentic formation of proliferation of cells in the glomeruli. The third differential we considered is lupus nephritis. So it's a form of glomerulonephritis that occurs as a major organ manifestation of SLE. Patients are usually ANA and double-stranded DNA positive. Clinically, it presents from asymptomatic proteinuria, microscopic hematuria to rapidly progressive glomerulonephritis. Kidney biopsy findings showed mesangial widening and hypercellularity. As you can see on the slide or on the picture on the right corner, how the mesangial widening as well as hypercellularity is marked with the yellow. Fourth differential we considered is thrombotic thrombocytopenic purpura. It's a rare microangiopathy which is characterized by microangiopathic hemolytic anemia, severe thrombocytopenia, and ischemic organ injury to platelets-rich clots due to severe deficiency of von Willebrand disease cleaving protease ADAMTS13, thus leading to large von Willebrand factor multimers which causes the platelet activation. This disease causes clots in cerebral, kidneys, and cardiovascular system. Early plasma exchange is the key. Untreated TTP has higher mortality rate up to 90%. Fifth differential is meningoproliferative glomerulonephritis. It is not a single disease but rather a histopathological diagnosis characterized by thickening of glomerular basement membrane, mesangial hypercellularity. There are various forms predominantly divided into three types: immune complex mediated, complement mediated, and membranoproliferative glomerulonephritis without immune and complex mediated. It has various etiologies from autoimmunity to immune response due to infections, especially viral infections and some bacterial infections. The slide shows how renal biopsy will appear in patients who suffer from membranoproliferative glomerulonephritis. So back to our case. Our patient had broad workup as I mentioned you earlier. In infectious workup, patient urine showed proteinuria, hematuria. Her urine culture was also positive for E. coli and strep pyogenes. Patient stool and culture as well as PCR was negative. Patient did receive 1 unit of packed blood cells and platelets for anemia and thrombocytopenia. Patient blood smear showed positive schistocytes and low heptoglobin. However, patient ADAM TS13 enzyme level was normal. Patient also had renal imaging and biopsy done. Her renal ultrasound and Doppler was completely normal. Patient kidney biopsy, which was done and resulted on day 4 of her admission, which shows thrombotic microangiopathy, as you can see on the slide with the arrows marking. So thrombotic TMA, thrombotic microangiopathy, means the small renal arterioles are full of thrombi. This slide also shows the findings of acute tubular necrosis. Her immunologic workup showed patient ANA, double-stranded DNA, CNCA, PNCA level were all negative. Her workup for catastrophic antiphospholipid syndrome was negative. Patient atypical HUS panel was negative. Patient also had genetic testing done for atypical HUS, which was negative. So the diagnosis which we suspected for our patient was atypical HUS because her renal biopsy showed TMA, thrombotic microangiopathy. She did have AKI. She did have thrombocytopenia with negative infectious toxin, especially the Shiga toxin. Her autoimmune workup was also negative, so the whole process was due to complement mediated, and our patient did have low complements level. Thus, the final diagnosis came up to be atypical HUS. So, our patient, in terms of the targeted therapy, did receive IV steroids, IV solumedrol, which was transitioned to the oral steroids. She was also started on eculizumab on day 4 after the renal biopsy showed characteristics finding of TMA. Patient was then transferred to pediatric floor on day 5, where she did receive intermittent hemodialysis until discharge, and finally she was discharged on revaluzumab, which is an oral version of eculizumab. So the learning points from our case is to recognize atypical HUS can present as purpuric rash, AKI, thrombocytopenia. Understand that genetic testing for atypical HUS can be negative in 30 to 40% of the cases. Recognize presentation is rapid and requires complement blockage with eculizumab. We have to maintain the broad differentials when a patient presents with such complaints. Recognize eculizumab or revaluzumab are the treatments that can be life-saving in atypical HUS. Recognize early plasma exchange is critical for thrombotic thrombocytopenic purpura. Special shout out to my mentor, Dr. Ashma Goel Garkha and Dr. Tanya Paul, who helped me in preparing this case. So if you have any questions, you can reach out directly to me on my email stated below. Thank you so much. Bye.